Hello, everyone. It's the top of the hour, so we'll go ahead and get started. So welcome. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, Candida Auris, What is it? Can we stop it? Featuring Dr. Rachael Lee, Associate Professor in the Division of Infectious Diseases at the University of Alabama at Birmingham, and Chief Healthcare Epidemiologist for the UAB Health System, and Ms. Mary Duncan, Senior Director of Infection Prevention for the UAB Health System. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email arcipc@uab.edu with any questions and stay up to date about future trainings by signing up for our newsletter on the homepage of our website. We would like to thank our co-sponsors for today's webinar, the Deep South Safety for Occupational Health and Safety, and the Alabama Public Health Training Network, a division of the Alabama Department of Public Health. You can learn more about their programs and these centers as a whole at their websites listed on this screen. We'd also like to let you know about our next upcoming program. We will be inviting Dr. Stella Aslebekian back to provide an update on her research around long COVID, which attempts to understand who is susceptible to long COVID, how long the symptoms can last, and whether vaccination can improve long COVID outcomes. This webinar will also be presented by the Alabama Public Health Training Network and the ARC-IPC. It will be held on Wednesday, May 3rd at 12 p.m. Central Standard Time. More information will be available soon. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, and complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not need to submit directly to the Alabama Board of Nursing. Please allow 2 weeks for CEUs to be added to your dashboard. CE units for this program will expire on March 10th, 2024. If you experience any issues, please email arcipc@uab.edu. We will also place this email address in the chat box. And finally, it's my pleasure to introduce our speakers. Dr. Rachael Lee is an associate professor in the Division of Infectious Diseases at the University of Alabama at Birmingham and is the chief healthcare epidemiologist for the UAB Health System. Dr. Lee completed medical school at the UAB School of Medicine, residency at UAB in internal medicine, and fellowship at UAB in infectious disease quality and patient safety. Dr. Lee joined the UAB Division of Infectious Diseases at UAB in 2016. In her role as UAB Chief Healthcare Epidemiologist, she utilizes evidence-based medicine to prevent the spread of healthcare-associated infections. Her research focuses on multi-drug resistant pathogens as they relate to infection control. Dr. Lee is an expert in all things infectious disease related, ranging from the spread of diseases like the flu to infection prevention and control. Mary Duncan is an experienced certified infection preventionist who has spent the last 18 years implementing best practices at various facilities to prevent infections in patients. She is currently the Senior Director of Infection Prevention at the University of Alabama at Birmingham's Health System. This is a 1,100 plus bed level 1 trauma center in the city of Birmingham, Alabama. Through her passion and innovative approaches, she strives to decrease infections by working with frontline staff to make sure that they are educated on best practices and have access to the tools they need to do the right thing. Mary is skilled in the ability to listen and identify issues or problem areas and form innovative solutions that increase the safety for both patients and staff. And without further ado, it is my pleasure to turn things over to Dr. Lee and Ms. Duncan.
I think when Mary and I first started talking about wanting to develop this webinar, it really came out of a place of having to deal with it. When we first started seeing our Candida auris cases at UAB, we really took a deep dive into the literature and making sure that we are doing what's best for our patients. And so we want to take that information that we've learned and be able to share that with you today. Here are our objectives for today. We want to describe the epidemiology of Candida auris and why healthcare systems should care, identify how to create a screening process for Candida auris, describe what cleaning and disinfecting processes are most effective in killing Candida auris, and then highlight key differences in infection prevention practices between hospitals, skilled nursing facilities, and long-term care facilities for preventing the spread of Candida auris. So Candida auris, in terms of epidemiology, you may have been hearing recently about HBO's Last of Us, the zombie fungus that is actually based on a real-life species that performs some sort of mind control on its insect host. And so this is getting all the rage right now, including, can we imagine a pandemic caused by a fungus? But what I would say is that what's really actually more scarier for me is actually the fungal crisis is already here. And this is really in the form of Candida auris. This is a Stat News article that was published February 9th, where the Mississippi Department of Public Health announced that they had 6 people infected with Candida auris. And so we are seeing these numbers increase. And so what can we learn and from our lessons past in terms of preventing it going forward? Why is Candida auris a problem? Well, number one, it causes serious infections. So we know that they can cause bloodstream infections. And when we have these serious invasive bloodstream infections, more than 1 in 3 patients can die. It is often drug resistant. So as a clinician, when we have a Candida or a yeast in the bloodstream, we have something called fluconazole, but it's commonly resistant to these antifungals that we use to treat our standard Candida infections. It's becoming more common. So since its discovery in 2009, it has spread very quickly to multiple countries around the world. It can be difficult to identify, and I will highlight that a little bit later because of this misidentification that can occur in public health laboratories. And then lastly, it can spread in hospitals and nursing homes, and that can cause outbreaks. So Candida auris was originally identified in 2009 in Japan from an ear canal of a hospitalized patient, hence the name auris, which is Latin for ear. It's thought that maybe this became a human pathogen due to overuse of antifungal agents, or potentially it evolved from thermal adaptation from climate change. Despite its name though, Candida auris really more commonly causes bloodstream and intra-abdominal infections than it does ear infections. It can colonize the skin and it increases your risk for then developing a bloodstream infection. So there's some data from New York State from 2016 to 2018, where 4% of Candida auris colonized patients developed a bloodstream infection, which that's a rate of about 0.3 bloodstream infections per 1,000 patient days. And really, patients that developed that infection had some sort of portal of entry, like an indwelling medical device or some sort of wound. I love this quote from this Annals of Internal Medicine article that said, from an infection control perspective, Candida auris acts more like a multi-drug resistant healthcare associated bacteria than it does a typical yeast. It is a new bug using old tricks mastered by some of these well-known multi-drug resistant organisms that we already deal with on a daily basis. Now, I mentioned a few risk factors for Candida auris, but common ones include older age, if you've had some sort of nursing home exposure, if you have an invasive device, and that includes a tracheostomy tube or a percutaneous gastrostomy tube. If you're immunocompromised, then that, or neutropenic in some sort of way, then that can increase your risk of having Candida auris. If you have been exposed to broad spectrum antimicrobial drugs, then that can put you at risk for having a yeast type infection. If you have had a long hospital stay that you're exposed to the healthcare system for a prolonged period of time, that is an increased risk. And then lastly, some other drug-resistant organisms, if you have a risk of having those, like Acinetobacter, Pseudomonas aeruginosa, or Klebsiella, then we've also seen those patients have Candida auris. Now, globally, the rates of Candida auris have increased substantially since 2009. And the way that these are categorized is in terms of clades. Now, this figure on the right only mentions clades 1 through 4. And those correspond to South Asian, which is where it was initially identified, East Asian, African, and then South American. And then more recently, Iran was identified to have a 5th clade. All of these clades, except for clade 2, which is one that actually does cause ear infections, have been linked to outbreaks of invasive infections. And there have been large kind of molecular investigations of Candida auris outbreaks, some done by the CDC, and they show these clusters of these highly related isolates. And that really just supports the idea of local and ongoing transmission. What's unique in that is countries like United States or UK or Germany, they have this genetic complexity. And I think this has to do with just multiple introductions into these countries with Candida auris. So speaking of the United States, when we first started hearing about Candida auris from 2013 to 2016, it was really limited to 2 different states, Illinois and New York. But as you can see, as time went on, we've continued to add more and more states that have had cases of Candida auris. With that came a significant increase in the number of cases within those states as well. So fast forward to 2022, and this is our current data through December 31st of 2022. There have been 2,377 clinical cases and 5,754 screening cases. So this number has been going up substantially since 2020. And so I think we can all remember what happened in 2020, and that's COVID-19. And we have seen a significant uptick in these cases since that period of time. So what about SARS-CoV-2 and Candida auris? What is it that's going on that has led to these increase in cases? And so this study actually went through and described a lot of the different outbreaks that have occurred of Candida auris in SARS-CoV-2. And a lot of this has to do, especially initially in 2020 and 2021, we had a large number of critically ill patients in intensive care units. They had co-infections that were reported. And in some of these, as you can see, there was a specialty care unit in Florida of 67 patients, of which 52% were identified to have Candida auris. There was a COVID-19 hospital in Mexico with 12 patients, 15 patients in New Delhi, 14 patients in a Lebanese tertiary care center. And then in Southern California, the newly identified Candida auris cases from March to September of 2020 more than doubled from 15 to 73. Now, if you look at this figure on the right-hand side, you can see this is a tornado diagram. And on the green are the specific risk factors that were identified during these outbreaks. And then the yellow are the corresponding containment measures. So number 1, inadequate PPE, hand hygiene adherence. You can see that one of the main ways that people used to mitigate the number of cases of COVID-19 are PPE and hand hygiene audits. But some of the things were very difficult to deal with, right? PPE shortages, so many hospitals dealt with that at that time. Prolonged critical illness is not something that we can necessarily change when we're dealing with something like COVID-19. And then also with the pandemic and patient overcrowding, it's very difficult to mitigate that. But there are some things that hopefully going forward, we can help kind of discuss what hospitals can do if they start seeing Candida auris. Now, this is another hospital outbreak of Candida auris. This is pre-COVID-19, and this was done in New York City. It was citywide, multiple institutions, and they identified in this outbreak 51 cases, of which 45% of the patients died within 90 days. Most of these were resistant to fluconazole, that antifungal medication that we were describing. And so what these hospitals did, they did screening cultures that of over 500 patients, and 11% of those were positive. And they also did environmental cultures and samples from 15 that were positive from 15 out of the 20 facilities. What this figure shows on the right, so those dark bold boxes are actually hospitals, and then the non-bold boxes are long-term care facilities. And I think what this really just shows everyone is something that we don't think about very frequently, is how often patients transfer from a hospital to a long-term care center to home and then back again, or to maybe another different hospital. And so with that, we can see this transmission of Candida auris if we aren't aware of those patients moving so quickly back and forth. The other thing that they identified in this study is how long patient colonization can last. So these red dots are positive cultures. The blue diamonds are negative cultures, and then the X is a deceased patient. But by far and away, you can look at some of these patients remained positive for days and days and days, including this third one up here on the top. It was over 200 days remained positive with Candida auris. And we've seen similar data to this with our other multi-drug resistant pathogens like CRE, where patients who are colonized, that colonization can last quite some period of time. The other thing that this study did with those environmental cultures is that they looked at different areas. So in the patient room, around the patient room, and then outside of the room. And so not surprisingly, in the patient room, there's a vast majority of positive cultures, particularly the IV poles, the bed, privacy curtains, et cetera. And then when you start moving kind of like to objects in the rooms, the walls and the bathroom countertops were also positive. What's interesting is the equipment outside of the room. If you look down here at the dialysis equipment, 1 out of 7 those samples were positive. So that indicates how you can see some of this Candida auris spread in your facility from one single patient. Now, in terms of Candida auris diagnosis and treatment, I mentioned that Candida auris can actually be incorrectly identified in the microbiology lab. And that's really based on the type of laboratory equipment and the testing methods that are employed. If you grow it up on a culture plate, it has this shiny, smooth, whitish colonies that are on this fungal growth media. But depending on your system that you use, the Vitex system or API, some of those have these precast panels of growth media, and so that can misidentify the Candida auris. Now, there are some other ones called like MALDI-TOF, which is actually much more accurate. This is a great study that looked at all of the different cases of Candida auris in which they were actually misidentified initially. And I didn't show, the table was like 3 pages long, but you can see here that this one, the very top, these are blood and urine cultures, BAL cultures, and they were initially misidentified as Candida hemolonii. And so if you have something that is misidentifying, you may miss the fact that you may have Candida auris in your facility. Now, what I will say is that the CDC has really outlined the different panels that people may have and how you can talk to your microbiology lab, depending on their system, to make sure that they have a process to identifying Candida auris. So for instance, I know that we have the microscan initially for some of our systems, but we also have MALDI-TOF and we have the GenMark. So our lab has gone through this process to make sure that we're not misidentifying Candida auris. The other thing is that some system actually may only say Candida species. And so given that there's a lot of treatment that's empirical for Candida, such as fluconazole or echinocandins, you may not be treating the patient right. So we want to make sure that you have the appropriate identification of the species so that you can really focus your efforts on the right antibiotics. So in terms of susceptibility, this was a study that looked at over 300 different isolates to determine which antibiotics are resistant. And so fluconazole, like I said, is a very commonly used one, and nearly 80% of these are fluconazole resistant. And about 67% of these were amphotericin resistant, leaving some to only be able to use one type of antifungal. Now, multi-drug resistant, which is resistant to 2 or more of these, occurred in about 70%. And they also identified XDR, which is extensive drug resistance to all of those classes. And so those have occurred. And if you, as you can really realize, if you don't have something to treat, then you potentially may have high morbidity associated with that. And so to that point, this is Candida auris isolates that were resistant to all 3 types of antifungal medications in New York in 2019. And these were 3 different patients that were identified, and they had multiple comorbidities. None of them had foreign travel. And despite all the efforts of everybody looking into these cases, there were really no epidemiologic links identified. No pan-resistant isolates were identified among contacts or the environmental equipment when they did cultures. And what they think may have happened is that all of them were initially sensitive to echinocandins, but then that resistance emerged during treatment with those medications. So all that to say, if we can prevent this from happening to begin with, then hopefully we still can maintain some of our antifungals when we need them. So I'm going to hand it to Mary to talk about infection prevention with Candida auris.
Now to have a little history behind what Candida auris is and how it has evolved, I'm going to give you some concrete things that you can do to prevent this fungus from spreading further and becoming a major issue in your facility. So it's important to note how imperative it is to have a very strong infection prevention program in place in your facility in order to prevent the spread of this fungus, as well as other organisms of concern that are definitely going to evolve over time. Quick recap of what we've already learned. So we know that Candida auris can live on a patient's skin. Most commonly, it's in the axilla and groin. We don't know the exact length of time that a person can remain colonized, but we do know that it can be well over 3 months. We know that a colonized person, that a colonized or infected person can shed Candida auris, which can result in a transmission to other individuals. And finally, we know that a person who is colonized with Candida auris can develop an infection if the opportunity presents itself. For example, putting in a central line or putting in a Foley, if the immune system is compromised, or if the skin becomes disrupted, either by doing surgery or development of a wound. And so having an infected or colonized patient with Candida auris in your facility greatly increases the odds that other patients in your facility will become infected or colonized. And this is really because as a patient sheds Candida auris, the fungus is able to live and survive in the environment for days or weeks. And this is due to its ability to form biofilms on surfaces. And studies have found that the items that are closer to the patient or the equipment that's used directly on the patient, such as an axillary temp probe or a ventilator, are more heavily contaminated. However, they were also able to find Candida auris on like ultrasound machines or mobile devices or nursing carts that are outside of the patient room. And so when researchers have looked at the most common modes of transmission, they really identified that direct patient-to-patient contact or indirect patient-to-patient contact, such as sharing the same room or being admitted to the room previously occupied by a patient with Candida auris, are the most common reasons for transmission. However, they also identified that sharing equipment that had not been adequately disinfected or contact with a healthcare worker's hands that are transiently colonized are also common modes of transmission. So by knowing how Candida auris is spread, there are key things that we can do to stop the spread. And the first way is to be able to identify cases of Candida auris. And this is accomplished by making sure that the lab knows to look for Candida auris and that it has the right test to be able to identify Candida species to the species level. And we'll address the screening of patients a little bit later. And then another key part of identifying cases is really to make sure that we're notifying the right people. So infection prevention and the health department really should be notified when a Candida auris is identified, and then they can help direct the next steps and what needs to be done. And then another important way that we can prevent the spread is to implement strong infection prevention practices. And we'll dive into this in the next few slides, but they're going to be like putting the patient on isolation, rigorous adherence to hand hygiene, using dedicated medical equipment, using single-use disposable equipment, making sure that the equipment is cleaned in between patients, and then doing some audits about the cleaning and different infection prevention practices and giving that information back to the frontline staff. And so all the things that I'm going to go over are supported by the CDC and other organizations that have been researching Candida auris and its spread since it was first discovered. And while the CDC does have a site that's dedicated to Candida auris, another great reference is their interim guidance for a public health response to certain novel or targeted multi-drug resistant organisms. So if you're in an acute care hospital or a long-term care hospital and you identify a patient who's either infected or colonized with Candida auris, you need to place them on contact precautions. And so ideally what this means is being placed in a single patient room with the appropriate PPE. And for Candida auris, it's going to be gown and gloves every time that you enter the patient room. And then restricting that patient to their room. So they can't be walking in the halls or going to common areas. If they do need to go to procedures, to try and make those the last case of the day so that those rooms can be cleaned really well before another patient is put in. A lot of facilities have created an extra level of contact precautions, so an enhanced contact precautions, just to bring an extra sense of urgency to this pathogen and the isolation that's needed. If there's a limited number of single rooms that are available, then they really should be reserved for patients at the highest risk for transmission. So those would be patients that have uncontained secretions or diarrhea. The patients can be cohorted with other patients that have Candida auris in a single patient room. The problem becomes that a lot of patients that have Candida auris also have other multi-drug resistant organisms, especially CRE. And so this makes it a little bit more difficult to cohort patients together. If you do have multi-occupancy rooms where you have two patients in there, it's really important to ensure that the healthcare workers implement strategies to help minimize transmission between the roommates. So making sure that they're changing their gloves and gowns and performing hand hygiene between patients, and then cleaning and disinfecting the shared equipment after each use. And then given that studies have shown that patients can remain colonized with this fungus for long periods of time, and the fact that there really isn't an effective decolonization protocol, patients should remain on contact precautions indefinitely, is what the guidance is right now. And so what this means is the patient's medical record needs to be flagged so that every time that they're readmitted to the facility or a facility that staff know to put the patient back on isolation. So if you work in a nursing home and you identify or receive a patient who has Candida auris, they should be placed on enhanced barrier precautions unless they have uncontrolled secretions or excretions. And then in that case, they would be put on regular contact precautions in the facility. So when you use enhanced barrier precautions, you're going to use PPE, which again is going to be your gown and gloves, when exposures to body fluids is anticipated or there's a high contact activity. So an example of this would be doing your dressing changes or your linen changes or giving a bath or caring for a Foley. And in these instances, the resident is allowed to be out of the room so they can, go to the common spaces. They're not, and that's why the CDC created enhanced barrier precautions so that the risk is minimized, but the resident can still participate and live a quality life. So for this to be successful in limiting the spread of Candida auris, the patient as well as the family members really need to be educated on the infection prevention activities that they can do to prevent the spread. So this would be making sure that they're doing good hand hygiene as they're leaving the room, that they're doing good personal hygiene, so they're taking their baths and changing their clothes to really minimize the amount of Candida auris that will go out into the other areas. So this here is just another slide that gives some more detailed examples of when enhanced barrier precautions would be needed. And it's important to know that enhanced barrier precautions are for all patients who have a wound or an invasive device, and even the ones that aren't known to be MDROs. So for enhanced barrier precautions, the PPE is really triggered by the task and not necessarily by the organism. So as with any type of isolation precautions, in order for them to work, we must ensure that the staff are aware of the measures that need to be taken to prevent the spread of the organism. So for contact precautions or enhanced barrier precautions, hand hygiene and the proper use of gown and gloves is imperative. If you're in a facility that doesn't do a lot of isolation, it's really important that you have a refresher in service readily available if a patient is placed on isolation. And then it's also important to make sure that all staff who would come in contact with this patient are educated on the appropriate precautions. So this would be your dietary or your therapies or social work or anybody else that might be entering the room. And then signage is also important and must be bold and posted where anyone entering the room is going to be able to see it. Having a gown and gloves readily available outside of the room is important. And then also making sure that someone's in charge of rounding on that room a few times a day to make sure that the gowns and gloves remain stocked. And then having a trash can positioned near the exit so they can easily dispose of their PPE when they take it off as they're coming out of the room. Hand hygiene is very critical to prevent the spread. So having alcohol-based hand rub easily accessible both inside and outside the room will really encourage the staff to be more compliant. And then monitoring for adherence to appropriate infection control practices by performing audits and providing feedback. So this would be on your hand hygiene practices, your donning and doffing of your gowns and gloves, as well as your environmental cleaning and disinfection. And really consider increasing the number of audits that are performed on the units when you do have a Candida auris patient present. And then we really can't forget how important it is to educate both the patients and their visitors about isolation and what they can do to help prevent the spread. So talking to them about making sure that they're doing hand hygiene when they're leaving the room and encouraging the visitors that are there to try and minimize close contact to prevent their clothing from becoming contaminated. So the decontamination of the room environment, particularly high-touch areas and medical equipment, is extremely important to prevent further transmission, as Dr. Lee showed in some of her other slides. Studies have shown that twice daily disinfection of high-touch surfaces in the room can be an effective way to control further transmission. So this can be accomplished by EVS doing their one time a day clean, but then every time a new shift starts, the nurse or PCT or whoever it's designated to really go in and take a disinfectant and wipe down all the high touch surfaces. And this will really keep the bioburden down in the room. Studies have shown that auditing the cleaning procedures and providing feedback to frontline staff greatly increases their compliance and their effectiveness to cleaning. Again, they may think that they're doing everything that they're supposed to. And so that different set of eyes to come in and point out different things is usually helpful to increase their compliance. And then although quaternary ammonium compounds are the most commonly used disinfectants in healthcare settings, they really have limited activity against Candida auris. And CDC recommends using an EPA registered hospital grade disinfectant against Candida auris. So when Candida auris was first identified, really the only disinfectant that was recommended was bleach. But since that time, lots of disinfectant manufacturers have done the studies and submitted their findings to the EPA and have been approved to kill Candida auris. And so this is going to be the EPA's list P, and that will give all the current products that are effective against Candida auris. Now, if your facility doesn't have these available, or maybe the ones that are recommended aren't okay to be used on the equipment, they can also use an EPA registered hospital grade disinfectant against C. diff spores. But regardless of which product you use, so for the C. diff ones, that's going to be list K on the EPA website. So regardless of the product selected, it's important to follow all the manufacturer's directions for use, including applying the product for their correct contact time. And the contact time is going to be the key piece that's going to make sure it has enough time to kill that Candida auris. Another important point is all healthcare personnel providing patient care should be trained on which mobile and reusable equipment they're responsible for cleaning and how to clean the equipment properly. So there's been numerous CDC and health department investigations that have found that healthcare personnel are often unclear on who's responsible for cleaning which equipment and how it should be cleaned. So because the equipment moves from room to room several times a day, if you think of your vital sign machines, your glucometers, we know that these can be an important source of spread of the Candida auris. So making sure that people know who's cleaning it and that it actually happens. And this is just a screenshot of what the list P looks like on the EPA website. And it looks like it's got the name of the disinfectant, and that has a contact time on there. So it's very helpful and very user friendly. And then, another thing that is come out and a lot of facilities are using are these no-touch room disinfection devices. Now, when it comes to Candida auris, the data on these, such as your UV lights and your vaporized hydrogen peroxide, it's really limited at this time, and the parameters required for an effective disinfection are not yet well understood. However, there is a lot of studies that are occurring with this. So if you are using UV lights or vaporized hydrogen peroxide, just make sure you reach out to your manufacturer to make sure that it's effective against Candida auris. And another important thing to note is these should only be used as a supplement to standard cleaning and disinfecting methods. So make sure that they go in, do the good cleaning of the room, and then these can be used in addition. And then, as with everything, communication is really key to help stop the spread of Candida auris. So when patients are transferred to other units or other healthcare facilities, really making sure that that receiving facility or unit knows that this patient has Candida auris. And I think this was very well shown in that outbreak in New York. So making sure that conversations are happening so that the patient, when they get there, can be put on a correct isolation. A decision to transfer the patient from one level of care to another should only be based on clinical criteria and the ability of the accepting facility to provide care. It should not be based on the fact that the patient has Candida auris or not. So if a facility is able to care for patients with other MDROs, then they really should be able to care for a patient with Candida auris. When initial cases or outbreaks are identified in an area, like Dr. Lee was saying, in Alabama, we're just starting to see a couple of cases here and there of Candida auris. It's really important for the public health department to communicate this information to other healthcare facilities so that they can be looking for it, and that the laboratories know to be speciating the Candidas, or if we're going to do screening, that they know where they can send the cultures to to have them look for Candida auris. And then as Candida auris goes and hits new areas, it's important to really have talking points. So when patients are identified as having Candida auris, that you can assure them or reassure them or their loved ones of what their risks are, and how to control this and maintain it. And then also, as other patients are coming into the facility, that they can feel comfortable if they've heard that there's been Candida auris cases in their area, that, what is the hospital or the facility doing to protect their loved one or themselves. But it is important that we let people know. So if you're a normal, healthy person that doesn't have invasive devices and some of the other risk factors that Dr. Lee talked about earlier, you are at very low risk of getting a Candida auris infection.
All right, so Mary and I are going to tag team this discussion about the role of screening in terms of Candida auris infection prevention. So, I showed this slide earlier about the number of clinical cases that we have seen in the United States, but behind that is the number of screening cases that have been identified. And similar to what we see since 2020, there has been an exponential increase in the number of screening cases. Now, a lot of this data is based in states that may have screening criteria for certain patient populations. And so I think we're really just starting to see the tip of the iceberg. Once again, when we have cases of invasive Candida auris, that typically occurs following colonization. So there's a 4% risk of bloodstream infection after that.
Right. So when we talk about screening patients, the most common areas are going to be your axilla and your groin. So if you are to the point where you need to screen patients, if you reach out to your infection prevention person or the Department of Health, then they really can walk you through step by step, which swabs do you need to use, what media do you put it in, how to package it and label it and get it sent off to be screened for the correct Candida auris. And here's just some criteria that I found in the literature about who should be screened on admission when you are identifying that there's Candida auris in your region. So hospitalized, if a patient's been hospitalized outside of the United States within the past year, again, like I said before, if they're infected or colonized with CRE, there's a little bit of an increased risk that they'd have Candida auris as well. If they're a current resident of a skilled nursing facility or long-term care facility, if they're on the ventilator or they have a tracheostomy. Those patients have been shown to have a significant increase in having Candida auris. Or if they've been transferred from a long-term acute care hospital where patients with Candida auris have been identified. This is a little bit difficult in bigger healthcare areas where there's a lot of, it's hard to identify which facilities are having Candida auris. Or if the patient's been in close contact with a patient with Candida auris infection or colonization. So they shared a patient room. And then to accomplish that, I mean, it just seems overwhelming. Like, how do we figure out who to screen and who not to? But the advantage of having an electronic health record is that you can create these screening questions as in your admission piece. And so these are just a couple examples of facilities that have done screening. And then once, if the patient's identified as a high risk, then an order would be sent to the nurse and she could get the screening cultures of the axilla and the groin.
So to that point, I wanted to highlight a little bit of the data that has been in the literature about screening. So this was Candida auris admission screening pilot that was done in select units in New York City from 2017 to 2019. And so it was a pilot project, and they chose to do PCR screening of the axilla and groin in select high-risk units. And what they found was that Candida auris colonization was identified in about 7% of their admissions. Now, when you break down that data a little bit further, you can see here this graph on the left-hand side shows you the proportion of hospital admissions who screened positive by a prior location. So not surprisingly, private residence was very low in terms of their positivity. Nursing home was about 6%, which is what we're seeing in the literature. But they did find another unit within that hospital that had 16% that were positive. So that potentially could indicate those positive, having a cluster or an outbreak in that unit, similar to what Mary had described on the prior slide. Now, there's some characteristics of between nursing home A, B, and C. Some of the biggest things that they found was patients who had a drain or a central line, were the ones that had the highest risk of having positive cultures. So what are some steps for healthcare facilities to follow when faced with Candida auris? So Mary and I felt that, since we have gone through this similar process, let's give you the step-by-step of how to deal with Candida auris in your facility. So number one, notify. If you identify your first case of Candida auris, we highly recommend talking to your state health department. Every state has different criteria that for those that are required by notifiable diseases. Alabama does not require that Candida auris be notified. However, we highly recommend partnering with your county health departments and the state health department. And this is the form that you can use. This is the communicable disease report card. And if you choose case of public health importance, they can really help in terms of identifying if there's anything else that you need to do, or connect you to the CDC, which will help perform getting some of the screening tests, et cetera. So we really recommend partnering with the state health department in those cases. So the next thing that you should do is screen. We want to screen to detect ongoing transmission. So, and the best way to do that is something called a point prevalence survey. So you just take every patient on a unit or floor where transmission is suspected and you screen them. And so this was a study that was done in the Annals of Internal Medicine. And after Candida auris was detected in 4 facilities in Orange County, the authors then conducted point prevalence surveys that were repeated every 2 weeks, and then a comprehensive assessment of infection prevention and control practices for all 17 LTACs and SNFs in this study. They did enhanced surveillance methods, and that allowed them to gauge the extent of the Candida auris burden 3 months before they actually saw their first positive clinical culture. And so any facility in this group that was identified to have a positive prevalence survey with 1 or more new Candida auris screening had subsequent screenings done every 2 weeks in the axilla and groin to detect new positive cases. And so some of the interesting things that they found that we'll describe a little bit further is these gaps in terms of hand hygiene, transmission-based precautions, and then environmental cleaning. Another study looked at Candida auris colonization and environmental contamination. And this was a point prevalence study that looked at residents' bilateral axillary and groin skin swabs. And then they also did environmental samples during a point prevalence survey in a ventilator capable facility that had a high documented colonization. In addition to this, environmental samples were collected on the doorknobs, the windowsills, the handrails in each of the rooms. And so overall, they found 17 positive Candida auris patients in 8 of the 12 sampled rooms. And then also environmental contamination was detected in all 8 of those rooms with the positive residents, but then they also found it in 2 of the 4 rooms that were occupied by negative Candida auris residents. And so you can see how difficult it can be to monitor for transmission if you have these patients in red, which are your Candida positive patients, but then you have one that's here red, but then this green one that's negative. So it can be concerning when you have them in the same room as one another. And it can also be very difficult for nursing facilities that have limited space to be able to move those patients around and put them into negative patient rooms.
Now, if you've identified a patient that has Candida auris in your facility, and you know, how do you monitor and follow up to make sure that it's not spreading? And so really, it's like Dr. Lee talked about, conduct serial point prevalence studies on units where Candida auris transmission was suspected. And this should be done every 2 to 4 weeks until you've had at least 2 sequential point prevalence studies that did not identify new cases. And I will say that here at UAB, we did this, and it really gives you a sense of comfort to know that patients are not picking up Candida auris within your facility. However, if you live in an area that has a lot of Candida auris, sometimes it's a little bit more difficult to get to 0. And so that may not be feasible. So in these situations, maybe very low rates of transmission are going to be okay and appropriate. But it's still important to make sure that there's strong adherence to infection control measures, as well as admission screening and periodic point prevalence studies. And really, this is where bringing in your health department can be so beneficial, because they'll know what's happening in the community and really can help you come up with a game plan of what should be done. And then also they would be available to come in if you're having an ongoing transmission to help you look at other areas and other things that maybe you should be doing. Or maybe we need bigger discussion and regional awareness about Candida auris. So some of the other facilities know that Candida auris is in the area, and maybe they enhance their cleaning techniques or start doing some screening processes. Now, when we talk about environmental sampling, like this seems to be the go-to of what everybody wants to do. If you identify something, they want to culture everything to see where it is. But this really isn't recommended, you know, because just because you don't culture from that area does not mean that you could say that there's no Candida auris in the facility. There are some times where environmental sampling might be helpful. So if you're having a large outbreak that you just can't seem to be getting under control, it seems to be maybe in particular rooms or in a particular unit, maybe some environmental sampling could help you pinpoint maybe a problem area. Or if you're doing a study or a research study, that might be helpful to do that. But again, you know, consulting with your public health department is really important when you're thinking about doing environmental sampling.
Yeah, I 100% agree. It may seem a little counterintuitive given that we're showing slides where they've done environmental contamination cultures, but I think in real world, it's more important to focus on the infection prevention efforts, unless, as Mary described, you know, you're having a scenario where you're having ongoing transmission and you cannot find the source. Similar to this, you know, in terms of point prevalence surveys, you can have patients who may test positive for Candida auris and then that on their point prevalence survey test negative, which actually happened to us in our facility. That does not mean that you then take them off of isolation, because we still want to continue indefinitely. Once you are positive for Candida auris, until we get better understanding from the literature, we continue that, unfortunately, lifelong. So third step, in terms of after identifying your first case of Candida auris, is really to enact IP mitigation efforts and audit practices that Mary has already identified and outlined for you. And so this was that study, once again, from the LTAC and SNFs from in Orange County, California. And they identified substantial infection prevention and control challenges in these SNFs and LTACs that likely contributed to Candida auris and other multi-drug resistant organism transmission. But it improved significantly with public health infection prevention oversight. And so really, the literature described limited resources and oversight in these facilities that can hinder effective infection prevention and control implementation. And so that we've seen similarly during COVID-19 pandemic. And so in this study, they found that facilities that received this intensive on-site infection prevention and control support had improved practices on their follow-up assessments. So if you look at this LTAC here on the left, LTAC A, 67% had observed adherence to these hand hygiene opportunities, and that increased to 100% after education and training. And similarly, they had 61% in terms of their environmental training, and that improved to 88%, which is a significant improvement given how frequently these patients move in and out of the facilities and they have high touch objects, et cetera. And so lastly, if you have your first case of Candida auris, you can consider whole genome sequencing. So this study from the LTACs and SNFs identified that this outbreak resulted from a single introduction to the region following undetected transmission in local facilities before that first case was identified. The CDC does have an antimicrobial resistant lab network that's available for whole genome sequencing, and our state health department can help connect you to the regional place for being able to test for that. We have sent some of ours out for whole genome sequencing. That does not change what you do in terms of your infection prevention and control strategies. That's just an added layer of understanding how this entered into your facility and potentially transmitted. So in conclusion, we know Candida auris can cause large outbreaks. They're difficult to contain. They have high mortality rates. And so the knowledge and scope of the global burden really is incomplete, and that's likely due to issues with both diagnosis of infection and colonization. And so if you have proactive protocols for your outbreak investigations and containment measures across the entirety of the healthcare network, rather than just a single facility, I think that is what's necessary to control Candida auris in the United States. All right, and then if you do get the slides, we do have reference slides at the end. And so Mary created these in hopes that if you do have your first case, you can actually go to those as their source for finding the data that's we've mentioned here.
Thank you, Dr. Lee and Mary. Dr. Lee, I believe you answered the question that was in there about intermittent negative results for patients. Yes.
Correct. So Melanie from the Department of Public Health has seen this frequently, where we've had patients that have screened positive and then they screen negative. Then it can be very confusing to our healthcare workers. What does that mean? Do I take them off of isolation or not? And at this time, we maintain isolation. And if they are positive, then you don't necessarily need to continue to do that surveillance screening on those patients.
Another question, should healthcare personnel be tested if they have cared for a patient with Candida auris infection?
So my personal opinion is no. I think we don't do that similarly for taking care of Staphylococcus aureus, for taking care of other multi-drug resistant organisms. I think the key here is you want to perform hand hygiene frequently, regardless of whether or not you're going into patient care areas, and then wear the appropriate PPE based on the potential exposure. Mary, do you have anything to add there?
Yeah, I agree with you. The studies have shown that healthy people they may be transiently colonized, but they wouldn't be permanently colonized usually. So
we'll wait for another minute or so if I don't see any more questions. I see a lot of comments saying great presentation. This is a very challenging topic. So lots of kudos to both Dr. Lee and Mary.
Yeah, if I could just One last thing. So, I mean, this is newer to our region. And so there's a lot of uncertainty because we really haven't dealt with this yet. So there's lots of resources out there. The health department is a great resource to be able to reach out to. And I think the only way that we're going to be able to control it in Alabama is to really have open, honest conversations and really reach out and help each other and, use all the resources that we have to keep it contained.
Yeah, the other thing I would say is that we have a great toolkit already available based on our knowledge. And so this shouldn't prevent us from caring for these patients if they are colonized. I think the goal is to prevent that spread to other potentially vulnerable people.
I don't see any other questions, so we'll give everyone a few minutes back at the top of the hour. So thank you again, Dr. Lee and Mary, for your time and sharing your knowledge and expertise around Candida auris for our listeners and attendees. This is such an important and timely talk for those who are working in healthcare facilities and in the infection prevention sector. And thank you to our attendees and our listeners. We hope to see you at our next webinar on May 3rd on research around long COVID. Have a great afternoon, everyone.